The ATOP 2 payment reform model includes 3 types of payment: facility payment for treatment of the 6 qualifying conditions in-house at the long-term care facility, and 2 practitioner payments, one for the on-site treatment of an eligible beneficiary for one of the 6 qualifying conditions, and the second for care coordination and caregiver engagement. In order for a facility to participate, it must meet the eligibility requirements outlined by CMS. These include an average daily census of more than 80 residents, with greater than 40% of the total long-term care facility census as long-stay Medicare enrollees in traditional fee-for-service Medicare. This does not include Medicare Advantage. Long-term care facility census is defined as a beneficiary who has resided in the facility for 101 days or more. The facility must have at least a 3-star overall rating on Nursing Home Compare on the date of the funding opportunity announcement, which is August 27th of 2015. The facility must not be on the CMS list of special focus facilities. The facility must have no survey deficiencies for immediate jeopardy to resident health or safety within the last 12 months. They must not have had any sanctions, indictments, probations, corrective action plans, or judgments imposed in the last 3 years relating to fraudulent or abusive billing practices. And they must be Medicare, Medicaid certified, and not excluded from participation in the Medicare Medicaid programs. Residents must also meet eligibility requirements in order for the payment reform model to be applied. CMS defined eligible residents as those who have resided in the participating long-term care facility for 101 cumulative days or more, are enrolled in Medicare, Part A and Part B fee-for-service and Medicaid, or Medicare Part A and Part B fee-for-service only, have not opted out of participating in this initiative, reside in a Medicaid or Medicare certified long-term care facility bed, are not enrolled in a Medicare managed care plan, such as Medicare Advantage, and have not elected Medicare hospice. CMS states that these 6 conditions, pneumonia, urinary tract infection, congestive heart failure, dehydration, COPD or asthma, and skin infections, are linked to approximately 80% of potentially avoidable hospitalizations among nursing facility residents nationally. Under this new model, facilities are eligible to earn up to $218 per day per beneficiary. The duration of benefit is limited to 5 or 7 days, depending on the condition, and it is limited to eligible residents covered under Medicare Part B. In order to bill this additional revenue, new codes have been added for participating nursing facilities. Facilities can now bill the Medicaid nursing facility daily rate, the allowable Medicare Part D payment, the allowable Medicare Part B payment, and the new Medicare Part B payment to reach the total facility payment per day. The process for determining billing practices with the new codes is very straightforward. If a resident is appropriately managed in facility per CMS guidelines and experiences a qualifying condition, the facility must provide the resident with an in-person evaluation, completed by an eligible practitioner, within 48 hours of the acute change in condition. A qualifying telemedicine assessment must be completed in lieu of an in-person evaluation. If the resident meets the beneficiary eligibility criteria put forth by CMS, the new billing codes may be applied. The official requirements for treatment in a facility include a confirmation of a qualifying diagnosis by an MD, NP, or PA, either in person or by qualifying telemedicine assessment. This needs to be done by the end of the 2nd day after the change in condition. The evaluation must be documented in a resident's medical record. The 6 conditions have required interventions that the facility must be able to provide, and services must be provided in-house by facility staff or contracted service providers. Finally, the duration of the benefit is specific to each of the 6 conditions. We will now go through each of the 6 conditions, the required facility services, the maximum benefit period, as well as the billing code for each. Required facility services for pneumonia include antibiotic therapy, oral or parenteral, hydration, oxygen therapy and/or bronchodilator treatments, additional nursing supervision for symptom assessment and management, vital sign monitoring, lab or diagnostic test coordination and reporting. The maximum benefit period for pneumonia is 7 days. The facility billing code for pneumonia is G9679. Required facility services for congestive heart failure include increased diuretic therapy, the ability to obtain an EKG to rule out cardiac ischemia or arrhythmias such as atrial fibrillation that could precipitate heart failure, vital sign or cardiac monitoring every shift, daily weights, oxygen therapy, low salt diet, and review of medications, including beta blockers, ACE inhibitors, ARBs, aspirin, spirolactin, and statins, monitoring renal function, laboratory and radiologic monitoring, and if it's a new diagnosis, additional tests may be needed to detect the cause. The new billing code for congestive heart failure is G9680. Required facility services for COPD and asthma include increased bronchodilator therapy, usually with a nebulizer, IV or oral steroids or oxygen, and sometimes with antibiotics. The new billing code for COPD and asthma is G9681. Required facility services for skin infection include frequent turning, nutritional assessment or supplementation, at least daily wound inspection and or periodic wound debridement, cleansing, dressing changes, and antibiotics, oral or parenteral. The new billing code for skin infection is G9682. Required facility services for fluid or electrolyte disorder or dehydration include parenteral fluids, lab diagnostic test coordination and reporting, and careful evaluation for the underlying cause, including assessment of oral intake, medications, infection, shock, heart failure, and kidney failure. The maximum benefit period for this condition is 5 days. The new billing code for dehydration is G9683. Required facility services for a UTI include oral or parenteral antibiotics, lab or diagnostic test coordination and reporting, monitoring and management of urinary frequency, incontinence, agitation, and other adverse effects. The new billing code for a UTI is G9684. It is the responsibility of the facility to trigger the actual payment code. The code may be billed only once a day for a single beneficiary, even if that beneficiary has more than one of the 6 conditions being treated in the facility. The long-term care facility may also need to complete a minimum data set or MDS assessment for a significant change in condition, following standard MDS requirements. The benefit can be triggered again only if the beneficiary meets the qualifying criteria for one of the qualifying conditions. There is no requirement for a gap between benefits if the condition continues to meet the qualifying criteria after the maximum benefit period. However, a reconfirmation of the diagnosis by a qualified practitioner is required. This is a visual representation of an example of the facility payment model. For questions regarding ATOP 2 and payment reform in facilities, email Adriana Mahoney at amahoney@healthinsight.org or call 775-530-4215.